We'll now move to our next academic session. This session is dedicated in memory of Dr. Paranjape sir. I request Dr. Ashok Deshpande sir to please say a few words.
Now we have got a second session we are doing, and in this session we have got 3 lectures. This whole session is dedicated to Dr. Paranjape sir, and I don't think anybody needs who is Paranjape sir and what he has done, because most of you who are sitting here, they know Paranjape sir very well. But I would like to tell you one sentence only about him, that he was the person who used to work and work. And another point about him is that today is the day, that is his first death anniversary is today is the day. So I dedicate this session to Dr. Paranjape sir.
Thank you. Now move to our session. The topic for the session is anesthetic implications of obstetric hemorrhage by Dr. MEENAKSHI Sundaram. I request the chairperson and co-chairperson for this session, Dr. Joyshankar Jana sir and Dr. Jyotsna Paranjape madam, to please come on the stage. Dr. Jyotsna Paranjape madam is MD Anesthesia and MBA in Hospital Administration. She is present professor, head of department, Bharati Medical College and Hospital Sangli. We have Dr. Joyshankar sir now. He is alumni BJMC Pune. He has done his MD and DNB. He is affiliated to KM Hospital, Galaxy Care Hospital, Pune. He has many national and international publications. He has won Best Paper Presentation Award for Anesthesia for Robotic Surgery. He has held various important positions at state and national ISA. His areas of interest are anesthesia for robotic, advanced laparoscopy, cochlear implant, kidney, liver and uterine transplant surgeries. He is the first in India and Asia to give anesthesia for uterine transplantation for cesarean section after uterine transplant. Welcome, sir. Dr. Jyotsna Paranjape madam. She is the present professor, head of department, Bharati Medical College and Hospital, Sangli. She is PG examiner at various MD examinations in and out of Maharashtra, has numerous publications on her name and has organized various conferences for ISA and IMA. Thank you, ma'am. Now I request our chairperson to please introduce our guest, our speaker, Dr. MEENAKSHI Sundaram.
Dr. MEENAKSHI Sundaram needs no introduction. He is the most popular figure in Maharashtra. I don't know the number of visits he has done up till now. He is the Dean of Government Medical College, Perambadur, in Tamil Nadu. He was the past Vice President of ISA National, past GC members of ISA National, Professor of Anesthesiology for the past 18 years, and Dean of Government Medical College for more than 9 years. He is the academic chairperson for weekly webinars in ISA Pudikottai, under the captain of Pudikottai Budan, a Tamil poet, and released 4 poetry books and CDs. He is a Tamil scholar awardee by the government of Tamil Nadu, the only medical doctor to get this award so far. So let's welcome Dr. MEENAKSHI Sundaram, sir.
Thank you, chairpersons, for giving me a good introduction. In fact, I am delighted to have Dr. Joyshankar, Jana and Jyotsna madam to be the chairpersons for my speech. And I am really happy whenever I travel to Maharashtra, Dr. Jana used to be the driver. And today he is driving me as a chairperson. And madam, she is ever smiling and ever active, young intensivist. So far, I am seeing her for so many years. She is active in the same way, and I am happy to be here in Miraj, because frequently I used to come to Maharashtra. At least yearly twice I used to visit Maharashtra, but for the past 3 years I have not visited Maharashtra. And only day before yesterday, after a long gap, I have seen the airport. Then only I know there is a check-in process, that every time security check is there. So totally I have forgotten. Previously I was used to travel continuously. And after this COVID era, at least we had a interactive session physically, and I am really very happy, not by the strength of the audience for this scientific seminar. The same packed audience were there even for inaugural function. This is the first time I am seeing that. So I congratulate the Sangli Miraj, and they have done a very good show. Another point I used to say, in any scientific conference, there will be some people who will be always outside the seminar hall. they are outstanding anesthetists. I have seen some people will visit only stalls. They are stalwarts in anesthesiology. But only few people like you will remain in the seminar hall in the bench. You are the benchmark. So, I appreciate the benchmark audience. That too, for my session, the hall is packed. So, it is surprising fact. I think nothing interesting outside. So, I thank Dr. Deshpande sir and members of Sangli Miraj. Deshpande sir, I think he is here. Yes. Deshpande sir really made me proud and he has really made me tall. He has really made me tall and I am very happy for Deshpande sir. And see, he has visited even my son's marriage in my place, Tamil Nadu. So I used to say, I have visited Dr. Momin's daughter marriage. So this sort of an interaction the Maharashtra has given to me. So Maharashtra is for me, it is a home away from home. So let me give a brief introduction about anesthetic management of obstetric hemorrhage. See, the obstetric hemorrhage is a leading cause of mortality. Everyone is worried about that. Even today, I have seen a postgraduate presenting a management of placenta accreta. So I was happy that that girl managed a difficult case. And even the World Health Organization says, even in developed countries, the maternal mortality deaths are more. Now, because of the advances in interventional radiology, these complications are coming down. And we should have a multidisciplinary approach whenever torrential obstetric hemorrhage is there. So, you know, obstetrics is a bloody business, not obstetrician. Obstetrics is a bloody business, so we have to be careful whenever we are dealing with the obstetric case. And another point, obstetric is the only area, it is practiced everywhere throughout the country. If I say a cardiothoracic procedure or a neurosurgical procedure, it may not be practiced everywhere. But even in a taluk headquarters, even in a primary health center, cesarean sections are going on. So we have to be very thorough in managing an obstetric case. So why do we bother? If I show you a picture like this, then this falls will give a real hope. You will enjoy. But if the same thing it is a sign of beauty. If the same thing happens like this, it is a terrific sign. So we have to be very careful. And see, usually they will define all these academicians. They say what is obstetric hemorrhage? More than 1500 ml or blood loss more than 3000 ml in less than 3 hours. And see, blood loss of 150 ml per minute in 20 minutes. You multiply 150 into 20, it is 3000 only. But they say that 3000 less than 3 hours and 150 ml in 20 minutes. See, if I say this sort of definitions, you will be entering into a torture or you may be scratching your head like this monkey. But I will give you a practical point. Irrespective of this definition, the clinical utility will not be there by these definitions. Whenever you see blood, you assess it. You have to act fast. You know what is trickle of blood and what is a gush of blood. And imagining other hemorrhages, this obstetric hemorrhage is different. Trauma hemorrhage is different, obstetric hemorrhage is different. At the first look, it may look like same. Even this side, two side heads are different. If you look at carefully only, you will analyze. So same way, the obstetric hemorrhage is different. In what way obstetric hemorrhage is different? Up to 1000 ml may be normal in a normal pregnant mother delivering. And there is a difficulty in estimating blood loss because of dilution with amniotic fluid. Every problem will there. And it is challenging to the anesthesiologist. It happens suddenly. It happens suddenly, so only anesthesiologist can treat. And more than everything, you can manage the obstetric hemorrhage, however torrential it may be, but same time you have to manage the obstetrician also. That is the difficult part. Because they will not allow you to work. Bleeding, they will say. It is bleeding, but already we know that it is bleeding. But they will not, sir, what you have done, sir. So they will not allow us to work. So whenever there is a torrential obstetric hemorrhage, think of managing obstetrician also. And unfortunately, if the obstetrician is your spouse, you are gone. Because the obstetricians before joining OG, they will be like this. They will be like this only, most of you would have seen. But when there is a PPH, the obstetrician will be like this. You have to manage these people. That is important. So, why there is a difficulty in exact blood loss estimation? It is due to dilution of amniotic fluid. And the loss may not be revealed in case of concealed intrauterine bleeding or bleeding in any of the cavity, like peritoneal cavity or a retroperitoneal hemorrhage. There is a difficulty in blood loss estimation. So, you need a high clinical expertise to assess the blood loss. So, there is a difficulty in early diagnosis because the way we say hypotension, tachycardia, everything may be in pregnancy also. The tachycardia may not be a good sign in estimating blood loss, and hemodynamic collapse occurs, only larger amount of blood is lost. And there may be a delay in the interventional radiology part. Placenta is receiving so much of volume of blood per every heartbeat. So, whenever the bleeding is from placenta, it is profuse. And failure to recognize, it will lead to high morbidity and mortality. And you have to recognize the risk factors. That is also difficult. And investigation, you cannot wait for the result of the lab investigations. That is a problem in obstetric hemorrhage. So, you have to suspect, you have to treat. Whenever there is obstetric hemorrhage, it is better to over-treat than to under-treat. Right. Now, what are all the causes of obstetric hemorrhage? Remember this 4T: tone, tissue, thrombin, trauma. If you remember this 4, and if there is obstetric hemorrhage, another T is also there, that is torture mentally and physically. So, that is the 5th T. So, you have a cup of tea and think of these 4 T, then you act accordingly. So, as you know, I need not elaborate it, the tone, only PPH. So, the tissue, it may be a retained placenta or a membrane or clot. Thrombin, see, even the pregnancy like PAH can produce a coagulation abnormality, or coagulation abnormality may be a coincidental disease with the normal pregnancy. Same way trauma, most of the time this trauma is initiated by the doctors, either during cesarean delivery or a normal delivery. They will say LP. Honest, they will call, obstetrician will call me, sir, we had a case of LP. Then I will say, I will give LP, spinal anesthesia. So, whenever there is a lacerated perineum, so it is a common. So, you have to analyze all these 4T and manage accordingly. So, the antepartum hemorrhage, then they say it happens after 24 hours. So, the antepartum hemorrhage may be due to abruptio placenta or placenta previa. Uterine rupture can be antepartum as well as intrapartum. And most of the APH cases can be diagnosed by ultrasound. Even in the poster session I have seen, the case was referred from periphery, placenta accreta, ultrasound has not been done. So, in the present setup, if ultrasound is not done for an obstetric case, it is highly surprising. Because every week they are doing ultrasound, every day they are doing ultrasound. If they own their own machine, if they are sending it to somebody, it will be monthly once. If they have, it will be daily once. So, USG helps. Even in concealed hemorrhage, it is mandatory. So, in the intrapartum hemorrhage, it may be abnormal placenta, again it may be a uterine rupture or a low-lying placenta. So, previous so many reasons, wherever it is there, it is going to be hemorrhage only. So, the antepartum or intrapartum postpartum differs in the management by the obstetric intervention also. So, the abnormal placenta, as I said, it can be diagnosed by ultrasound. If there is a placental abnormality like placenta previa, it is always better to go for an elective cesarean section by explaining the risks involved and get an informed consent. And always counsel the patient and the attenders for the hysterectomy also. I have seen most of the times, even many of you would have seen, in the uterine rupture, they will be suturing, you will be transfusing 6 units of blood. At the end, they will say, sir, I am going for hysterectomy. That hysterectomy had they done already, the 6 units would be saved. And because of the blood transfusion, many complications will come after that. And once there is a irreversible hypotension, even if you do a obstetric hysterectomy, you may not recover the patient. So, first maternal life is important. next only the uterus. If there is a live baby, always resort to obstetric hysterectomy without wasting so much of time, especially in a peripheral setup where this blood bank facility is not available. And a uterine rupture is a life-threatening emergency. It can happen at any time. So take out the baby as early as possible. And as I said, you try to close the rent or go for obstetric hysterectomy. These are all obstetric management. Now, the million-dollar question. If the patient is bleeding or APH, what is the anesthesia of choice? If I ask Dr. Ravindra to talk about it, he will talk lengthier, even for half an hour or 1 hour. This problem will occur, that problem will occur, that you may opt for regional, but the problem will be like this, so many. But I will give you a clue whether it is a regional anesthesia or general anesthesia. If you want me to answer in one word, I will answer, you select. See, now this photograph depicts a system called regional anesthesia. Because even though the mother has delivered a baby just now, she is playing with the WhatsApp. Just like our national president remarked, they are playing with mobile phone. But I cannot find fault with her. She is not bothered about the general atmosphere. She is comfortable with the regional atmosphere. So, she is comfortable. We cannot blame that, right? Now, this boy not bothered about the regional atmosphere. He is concentrating on the general atmosphere. So, in his sense, he is right. In his sense, right, we cannot make a comment upon that. So, if there is a placenta previa, either you go for regional or you go for general anesthesia. I cannot make a comment upon that because a man on the spot is a good judge. So, if you ask me a straight question, I can't say. It depends upon the hemodynamic stability of the patient and the mental stability and experience of the anesthetist. That is how we have to decide that. So, the spinal epidural in spine stable patients, and if you want to give general anesthesia, it should be in an unstable patient where resuscitation is easy. So, postpartum hemorrhage, the worst thing, common thing which happens. So, it may be primary within 24 hours, it may be secondary up to 6 weeks, this postpartum hemorrhage. So, uterine atony is the commonest cause for this postpartum hemorrhage, we know. So, early administration of uterotonics will help these patients. So, what are all the uterotonic drugs? Uterus has to become rigid like a cricket ball. Now, I used to say there is an indirect proportion between the obstetrician's mentality and the uterine tone. If the uterus is hard, she will be relaxed. If uterus relaxes, she will pounce upon the anesthetist what you are doing. So, we have to be very careful with this. And the dose limitation is to be there. Anything used in excess, it is a misuse only. So, you can use oxytocin 20 to 30 units in 1 liter. So, if it is going to be 500 ml, it is going to be 10 units. Then, ergometrin. See, ergometrin nowadays it is not used for the simple reason it increases blood pressure and it produces coronary vasospasm, and all obstetric anesthesiologists, mainly AOA, they will be against the use. Straight away they will say no. But most of the time, this methyl ergometrin will be available everywhere. So, if at all, if it is not responding, uterus tone is not responding to any of the established drugs, you can try this methyl ergometrin. This is my personal opinion. If you are worried about this coronary vasospasm, you dilute it and give. But when I was a house surgeon, left and right we were giving methyl ergometrin, nothing happened. So, you can try for another reason also. Now, uterus is exposed not much to methyl ergometrin. It has seen so many prostaglandins, it has seen so much of oxytocin. So, suddenly it may be surprised to uterus, what new molecule is coming. So, it may contract. So, you can try this methyl ergometrin at times, right? So, this misoprostol and all, lot of misoprostol, everything will be pushed in by the obstetrician. So, whenever the uterus is not contracting, especially during a cesarean section, the anesthetist will be taken to task. They say you push 20 units of oxytocin. If you load oxytocin, they will you should give methyrgine. If you load methyrgine, they will no, you put a prostaglandin suppository, intramyometrial prostaglandin. So much of a tension is to be avoided. So you have to counsel the obstetrician also. It is their day-to-day business. They are dealing with the uterus. If there is a uterus, it will deliver as well as it will bleed. So we have to sensitize the obstetrician also. So if the drugs fail in obstetric hemorrhage, then you can try bimanual compression of the uterus and uterus massage. But most of the time as far as the uterus massage is concerned, as an anesthetist I have seen, the moment the baby is delivered, the staff nurse assisting will be trying to do that like that. Then she only gives a clue to the obstetrician, madam, it is not contracting. Obstetrician is not saying that it is not right. Most of the times you would have seen, even I have seen, we have to have record the so many speeches, conversations inside the theater. Most of the time it will be integrated by the staff nurses. So if you want to manage obstetric hemorrhage, you manage the staff nurse also. So then you can go for this B-Lynch sutures, balloon tamponade, everything you can try in an advanced setup. And really, the interventional radiology has reduced the morbidity and the mortality in the obstetric hemorrhage. So as I said, obstetric hysterectomy, you decide early so that judicious use of blood is there. After all, it is a divorce between the pregnant mother and the uterus. Nothing happens. Uterus will go. If at all the mother likes to have another baby by her itself, then we will approach Joyshankar, Jana for a uterine transplant. For that, the patient has to live. So the obstetric trauma can be small, large or severe. So accordingly, you have to act. If there is a small hemorrhage, leave it, conservative management. If there is a moderate or a massive hemorrhage, go for a surgical intervention. And always, when there is a hemorrhage, you prevent infection as well as septicemia. If there is a uterus inversion, before removing the placenta, if the uterus is going for inversion, first you reposition the uterus and then try to remove the placenta. So that is a good idea about the prevention of this obstetric hemorrhage. And for uterine relaxation, you have to pour a lot of inhalation agents. Then you have to remember coagulopathy. It may be due to that pregnancy-induced hypertension, or it may be coincidental. Sometimes PPH may be the first sign of von Willebrand factor deficiency, you have to remember. So when there is a coagulopathy, the treatment is going to be replacement of coagulation factors. If coagulation factors are not available, you can try FFP and cryoprecipitate or fibrinogen empirically. Don't wait for lab results, because they will give the result once the patient is discharged. So you have to be very careful, and whenever you are taking up the case for anesthesia, then you go for pre-anesthetic checkup. Mainly we are bothered about hemoglobin, but in India, the iron deficiency anemia is common. So even in the preoperative period, if you are seeing a case, even with the APH or anything, if you can wait, you try to use recombinant human erythropoietin or parenteral iron. Then investigate for coagulation also, and assess the intravascular depletion. Again I said, the heart rate and all, it will not be a good sign to detect obstetric hemorrhage, because in pregnancy itself the heart rate will be more. So if the urine output is less than 0.5 ml per kg per minute, definitely there is a intravascular volume depletion. We can easily monitor this. Then the interventional radiology suite, now really they are doing a good work, this embolization and the balloon tamponade, everything they are in a good way. So as far as possible, if the facility is available, even before surgery, preoperative period, we can occlude the bleeding arteries. So if a facility is there, if a patient is admitted in a state of shock, then you resuscitate and you accompany the patient if the radiology suite is there available. So in the intraoperative, you have to have an algorithm according to the place available. The algorithm may be different between my place Thanjavur and your place Sangli, but you have to have an algorithm and a multidisciplinary approach. If there is no multidisciplinary people, then multi-anesthesiologist approach you can have. Group practice, you have to help whenever the people call you. And absolutely there should not be any communication gap in the delivery suite or in the operation theatre when there is a obstetric hemorrhage. I stress, irrespective of junior, senior, obstetrician, anesthetist, technician, there should not be any communication gap, because communication gap itself can kill the mother. So we have to be very careful and you have to be very clear in communication. Who is the team leader? Who is going to communicate? Because if there is a communication gap, it may happen like this. Instead of Wi-Fi, in one hostel they said a good wife is available. So then there was a long queue. That is, so communication is important. Communication is important. Instead of Wi-Fi, they have written as wife. It is also not a problem. See, a big country like Malaysia, what is written here, read. You may not notice, that is communication. 25 million visitors annually. So, the communication is to be very clear, because at the first sight, you may not notice the problems. Only after careful observation, you will know what is the problem. So, always think twice, then communicate very clearly. Then maternal resuscitation. How we are going to do maternal resuscitation? If it is a minor bleeding, easily we can manage. But always have a IV line. First commence crystalloid infusion. In massive hemorrhage, again we are going for ABC. Assess airway, breathing, circulation, give oxygen. Because once the red blood corpuscles and hemoglobin are less in number, try to increase the dissolved oxygen carrying capacity. So you try to give oxygen by face mask. Then if there is a moderate bleeding, always try to have 2 IV lines. 14 gauge IV cannula we have to have. But most of the times they are having only 18, 16 and 14 are available. You have to have that. Even 12 gauge cannula is also available. These things will reduce the incidence of central venous cannulation. So large bore cannula to have. If you are not having that, have 3 or 4 18 gauge cannula. So until blood is available, try to infuse. But don't keep on infusing so much of a crystalloid. It will produce dilutional thrombocytopenia and it itself will produce coagulopathy. So try to restrict the crystalloid till the availability of blood. And when there is a sudden obstetric hemorrhage, even the blood filters, some people are removing the filters. That blood filters, they filter. Filter means they have to filter the debris, but they are filtering the whole blood, it is not allowing it to drop through the saline set. At that particular point of time, we have no other option. If somebody is blocking our way, we have to push and we have to go, whether it is right or wrong. So when there is a obstetric hemorrhage, when that filter itself is creating a problem, don't be concentrating on the filter. Try to concentrate on the patient so you can remove the filter. Same way the recombinant 7A factor should be applied whenever it is needed. And what is the monitoring you have to do? Monitoring, you have to do only lab monitoring. But if the patient is paler, it will take some time for her to improve. But the temperature and the capillary refill time, we can check. Then if the patient is in shock, if possible, check IABP. Check your IBP. But time should not be wasted for any lab result. That is again and again I stress, because even a coagulation abnormality, they may take 30 to 40 minutes to report. Even that 30 to 40 minutes is a problem. So first act practically, then go theoretically and scientifically. So volume replacement is immediate. And as far as possible, compatible red blood cells, good choice. Instead of whole blood, compatible red blood cells is a good choice. And try to have a hemoglobin greater than 8. Don't aim hemoglobin of 14. She may be having her original hemoglobin as 10. So if the hemoglobin is more than 8, platelet count is more than 75,000, prothrombin time within the control, fibrinogen more than 1 gram per liter, it is sufficient for resuscitation. And what is the fluid I have to give? Again, it may be controversial, but what I feel, not more than 2 liters of crystalloid and not more than 1.5 liters of colloid could be given in resuscitation till the availability of blood. But remember, the colloid may interfere with blood cross-matching, that you have to remember. But what I want to tell you, more than the amount of blood or amount of crystalloid, please concentrate on warming the blood. That is important. So all operation theatres, they should have a infusion warmers. That will be helpful, because that hypothermia, because of transfusion of cold fluids, it itself will produce a lot of complications. Always have plan B, because if one is not working up, we have to catch other. So that is life. I am saying that is life. It is not my life. It is a pregnant mother's life. So always I will have plan B for the pregnant mother, not for me. So don't mistake me. So RBC considered, as I said, you can try till the blood is available, you can try 3.5 liters, not more than 3.5 liters. And fluid for, if platelet is less than 50,000, transfuse blood platelet. If fibrinogen is less than 1 gram, go for cryoprecipitate. Then large volume fluid replacements itself can lead to disseminated intravascular coagulation. Then there may be a delay in lab reports, so don't wait for that. You can wait for a reasonable time. So the empirical treatment will be FFP. So the empirical treatment will be give 4 units of packed red blood cells, give 2 units of FFP, and this till the coagulation factors are available, you can try these empirical maneuvers, because it is recommended even by the British committee. If I say Indian committee, you may not follow. That is the reason I am saying it is a British committee. Okay, so a replacement therapy can be guided by ROTAM and all because of this coagulation, but ROTAM and the thromboelastograph, it will not be available everywhere. For the youngsters, I am saying, because when they come up as a practicing anesthesiologist, these things will be in handy. So you have to remember ROTAM and thromboelastograph, they can help in anesthesia management, even to select regional anesthesia. So after blood transfusion, you may resuscitate the mother, but complications like trolley, infection, cost escalation, you have to keep it in mind and monitor for complications also. Because once blood may not clot, but after replacing so much of a blood, the blood may clot and producing further problems. Then in obstetric resuscitation, it is not only maternal resuscitation, you have to resuscitate fetus also. See, in Tanjavur, I have taken this snap when I was traveling in my car. See, the mother is wearing a helmet for her protection, not allowing the babies to wear helmet. She is a nice mother because she is bothered about her own safety and not about their safety. But it is not like that in obstetrics. We have to save both the mother and the fetus. So there are so many monitorings available, but at the same time the electronic fetal monitoring, which is available everywhere, it should be monitored. Again, we have to be guided by the obstetrician only in this fetal well-being. If she says fetus is deteriorating, we have to immediately deliver. And the oxytocin itself can reduce the placental perfusion, so we have to be very careful in using oxytocin. Then we can try blood conservation strategies, but usually this autologous blood transfusion and all, it is used for cardiothoracic procedures, intraoperative cell salvage and all. Just for information's sake, I am saying it is not used, autologous blood transfusion is not practiced in obstetric anesthesia because the mother herself may be anemic. Then what is the amount of blood we can harvest, we don't know. We may not be knowing how much of blood she is going to last in obstetric hemorrhage. So the autologous blood transfusion is not allowed, especially, mainly it can be allowed for Jehovah's Witness because they are adamant in that because of their principle. Same way, the intraoperative cell salvage, it is controversial and most of the centers will not have that. So we need not bother about it. Recombinant factor 7A, it is for coagulation abnormality. Again, it should be available. Then only we can use that. The tranexamic acid and all, only in surgery, when there is a minor hemorrhage, uses this tranexamic acid will be useful, but in obstetric hemorrhage, it will not be useful. So, can I proceed or not? Yes. See, exactly carry home message has come. Because time is off, I have to do that only. Because time is not off. He has switched off my presentation. Right, in a carry home message. So the role of anesthesiologist in the management of obstetric hemorrhage is crucial. Right? This is for the carry home message for ladies. Now carry home message for males. Ulta. So here, the various guidelines available for management should be incorporated into a local protocol. As I said, it may be different for Tanjavur, it may be different for MEERAJ. Now, 1, 2. Now, multidisciplinary approach. Multidisciplinary. So, the multidisciplinary approach, you have to have a consensual planning, catalyzes the management even in crisis situations. This is carry home message. Now, I will give you take home message. Right? So, the take home message, I will tell you, in a multidisciplinary approach, men may come, men may go. Just because it is obstetrics, we will change it to woman may come, woman may go. But Anesthesiologist has to face all the pressure in obstetric hemorrhage and not pleasure. But we have to face the pressure with pleasure. That is anesthesiology. So how to manage obstetric hemorrhage as it is occurring in a rapid way, I will give you a clue. For MEERAJ people, I am screening a bikini show. So people are happy. Only for MEERAJ, this is especially for MEERAJ. So hold your breath. Many would be in swimsuits. I am clear in my communication. Many would be in swimsuits from backwaters. See? What you have expected, what had happened? That is the reason I said many. I have not mentioned any gender. Many would be in swimsuits. See, why I am screening this? This sort of unexpected thing can happen at any point of time. So expect the unexpected. That is obstetric hemorrhage management. So once again, I thank Deshpande sir, because Dr. Deshpande sir visited my place, my native place. It is just smaller than MEERAJ. It is 1/10 of MEERAJ. It is Rangiam. Even that village he has visited, and our chairperson also visited there with me and my mother during my son's wedding. So once again, I thank the Sangli MEERAJ, and I thank the uterus for the good contraction. Thank you very much.
Thank you, sir, for an educational as well as an entertaining lecture, as I may say.
No, where you want to use ketamine? It will not come, because whenever the patient is in a shock, like obstetric trauma, episiotomy tear or LP, at that time you can use it as a sedation if there are no other contraindications.
Because I will confront case here. 8-15 years ago, we referred to the case of same obstetric hemorrhage to Mission Hospital, and we later on we inquired there what you did. Then the madam said, yes, we gave 2 ml of ketamine for the patient, and patient was set.
No, it's not possible. When the bleeding, you want to say obstetric hemorrhage settled with 2 ml of ketamine? Absolutely no. Sorry. Then that may not be obstetric hemorrhage. Sir, who is bothered about our opinion, sir, regarding this prostaglandin? The obstetrician is pushing like that. Even this misoprostol they are putting. And see, any suppository can be inserted in vagina, urethra, rectal, any suppository. Then one obstetrician asked me, they are keeping that misoprostol vaginally. But in obstetric hemorrhage, that misoprostol is mentioned, it can be placed rectally, sublingually. Then the obstetrician asked, why, sir, it is not inserted per vaginum in obstetric hemorrhage? I said, when oral intake is contraindicated in vomiting, and diarrhea is a contraindication for suppository, when it is a bleeding, it is a contraindication for misoprostol. That's what. So, whether you go for anything, it is only misoprostol is commonly used. If you are asking me and allowed me to do that, I prefer misoprostol.
Thank you, sir. Thank you for the...
Carbotocin can be tried. That is a good choice. Carbotocin can be done. Yes, carbotocin can be tried. Yeah, carbotocin. Carbotocin is preferable. But see, whatever you are using for a longer time. See, I am comfortable with the oxytocin means I am comfortable with that. So once this oxytocin is not working, then when I try carbotocin, if it works in a good way, I have used only once, then I will use. This is just like, as long as the surgeon is comfortable with one anesthetist, they will be going together. When there is a problem with that anesthetist and when they change and they taste the skill of the other anesthetist, everything changes. So far I have not tasted the work pattern of carbitocin. So still I am using oxytocin only. I will be using only in reduced quantity. Actually, the obstetrician wants to use 20 units of oxytocin. But usually I will use 10 units, but I will break 4 ampules because he will check. So that and all you have to do, because see, I am doing it in a good intention. What I am saying, I am doing it in a good intention, and they will say, sir, you give methyl ergometrin at that time. When they say you give methergine, sir, I would have given one methergine. They will ask you to give another methergine. Then I will give one normal distilled water. See, It is everything is done in a good intention. See, you cannot educate a educated man, half educated woman. Half it is not possible. So don't waste your energy in that. See, they want something to be pushed in. The moment I push a dislodder, they will say, yeah, it is contracted. See, sir, I told you it has contracted. Right, okay, right, leave it. So don't pass on the message to Thanjavur. Still I am doing that only. See, with a good intention I am doing.
Any role of plasma expanders in hypovolemic or hemorrhagic?
Sir, it actually this they don't have any significant role. These volume expanders like plasma, colloid. Definitely, colloid will not give a good thing. But when something is available, we are using that. That colloid will always create a problem, especially if the patient develops hypotension. It is a problem. So a good deal will be if you are having a FFP instead of a plasma volume expander. If you have a plasma, you can use it as a plasma volume expander. That's a good choice. Instead of venturing with this colloids. Colloid that are not useful.
Now the time is running short. We have further lectures.
Madam, whether time is there or not, I have to catch my flight. That is the reason.
Thank you,
Let
sir.
us, you can ask at the time of lunch also.
Thank you, sir, for
Further
an
question.
interactive
Thank you, sir.
नंतर जाना सर.
Thank you, sir. I request Dr. Darshana Pandey, madam, to please felicitate our chairperson. Madam. Thank you, sir. Thank you, ma'am.